Dr. Utami, Noor, SYABANIYAH, please come to the dais.
Thank you. Good afternoon, everyone and organizing committee. My name is Utami. I'm delighted to present our study on retinal ganglion cell changes due to transsynaptic retrograde degeneration in posterior pelvic lesions. Axonal degeneration occurs when nerve fibers lose function after injury. If degeneration progresses towards the cell body, it is called retrograde. In transsynaptic retrograde degeneration, the damage in the central nervous system can cause atrophy in the neurons across the synapse. Stroke can cause visual field defects like homonymous hemianopia and also structural retinal changes, even with the normal fundus appearance. And occipital lesions can cause retrograde loss of retinal ganglion cell or GCC, which can cause GCC thinning, which can be detected by OCT and sometimes mirroring the visual field defect. Detecting these changes is crucial, and OCT can serve as a tool for this evaluation. Our purpose of this study is to explore the OCT parameters and the potential connection between the retinal GCC and visual field defect in stroke patients. So we included observed prospectively stroke patients with visual field defect, and we analyzed the macular GCC and retinal nerve fiber layer using OCT. We use the term hemifield atrophy to describe the loss of retinal ganglion cells in retinal hemifield corresponding with the homonymous visual field defect. And it is defined as significant GCC thinning in the affected hemifield less than 90% of the unaffected hemifield. I'm sorry, more than 90% of the affected hemifield. We will use only four sectors which did not crossing the midline. And we have 54 patients in this study. And our finding shows that around 63% of stroke patients with visual field defect showing visible hemiatrophy. And this GCC thinning were more significant seen in the patient with longer post-stroke duration. And we also found correlation between GCC thinning sectoral with the visual field defect. Here we present some of the cases of the GCC thinning with corresponding field defect in stroke patients. This one is female, 58 years old, with 3 to 4 months post-stroke. We could see that the lesion is on the left occipital area, and the Humphrey showed right homonymous inferior quadrant ranopia, and the OCT showed GCC thinning correspond with the visual field. Another case, male 59 years old with 1.5 years stroke in the right occipital area. Humphrey showed left homonymous hemianopia, and the OCT showed GCC thinning correspond to the visual field defect. This one also a female, 50 years old with 6 years post-stroke, with the Humphrey showed right hemianopia, and the OCT showed GCC thinning also correspond with the visual field defect. So to summarize, GCC thinning could be found in patients with stroke with visual field defect, and this could be serve as an indicator for TSRD in stroke patient with visual field defect. However, further study is required to understand the evolution of retinal ganglion cell complex during the process of TSRD. Thank you for your time. I'd be happy to take any questions.
What was the time when you performed the OCT? After stroke, how long after the stroke was the OCT performed on these patients?
So the mean time for the examination is 27 months, ma'am. The earliest is 1 month post-stroke, and the latest is 26 years. So we usually have stroke patients came to our clinic to see because he came for cataract surgery, and if there is if the patient was having a stroke before the history, then the cataract department will send it to us, and then we will check everything. So we use this patient to check the visual field and also the GCC.
Do you expect that in 1 month also you would find the GCC changes? Did
No,
you find?
no, but
But you included all of that?
yes,
Yeah,
yes,
data.
I included. I just want to know because from the references, first time they will show it more than 3 months, like around 5 months.
What was the incidence of diabetes and hypertension in these stroke patients?
Yeah, most of them have because they were stroke patients, sir. So they have hypertension and diabetes.
What if a patient of stroke also had glaucoma?
Here we exclude the patient with the glaucoma.
How did you exclude? Like, what if the changes were due to glaucoma? How did you exclude that there was no glaucoma based on the optic nerve pressure?
Yeah, first we check and then we also consult to the glaucoma if there is something, if there is something suspicious, but also we check from the IOP and then of the optic nerve also.
The other most important thing is the disc.
Yes, the disc.
Very important disc.
The disc appears normal, ma'am.
You have got the classification of that. Sometimes you have got what is called as the classification as normal disc with the pallor of the neuroretinal disc with pallor, focal notching, beam pot cupping. The thing is that the disc is important. Sometimes you have got what's called as a glaucoma suspect. Glaucoma suspect. Usually, old school of thought, whatever teachers taught us. Usually, glaucoma suspect, there's a tendency for the vessels to dip at the superior disc margins.
Yeah.
Physiological cup is prominent. But if it doesn't merge with the margin of the disc, then it becomes suspect. It's not only the question of intraocular pressure in the fields. There are 3 things, 3 F's. Fundus, fields, and the facility of aqueous photo. Obviously, now you have got a fundus photograph, you have got a OCT macula. It's a good presentation.
Thank you, sir.